her.
Okay, so we're ready and I'll start. So today's the 30th. Yesterday our target for GMLOS was 7. We only discharged 5 patients, so we were a bit shy of our goal. Today our GMLOS target is 7, so hopefully we can, it looks like there's some maybes from yesterday, maybe we can switch them over already. All right, 222 bed 1.
222, bed 1, initials SP, admitted on 327, expected discharge date 331, followed by sound. Plan A is skilled nursing facility, Plan B would be home with home health. Case management's going to call ProMedica this morning regarding insurance off. And then update from nursing.
From nursing, this patient is medically stable. They are still receiving IV antibiotics, so we can address that and see if we can change them to PO. They are on room air, they're independent, they're moderate with us, and they've had PT no T completed, but otherwise, yeah, they are good. Have they ambulated on your end?
Thank you for asking, Luna. No, nothing charted for ambulation, so if they're going to a SNF, they need to be getting up and participating, so we need to make mobility the goal for today.
All right, so for nursing action, document mobility, please, and IV to PO.
They're going to a SNF, they may not need IV to PO, but if it's appropriate, we can. Okay,
So maybe tomorrow for that one.
okay.
223, bed 1, initials TT, admitted on 327, estimated date of discharge 331, followed by sound. Plan A is home with family, Plan B is home with home health. Case management is going to follow up with patient regarding home health choice. And we may need to get an updated oxygen order if they are going to discharge higher than their baseline of 2 to 3 liters with a max of 4.
Okay, with nursing, this patient is progressing. They are still on IV antibiotics. They're utilizing continuous O2. They attempted to titrate below 3 without success. Patient drops below 90 with activities while on 3 liters. Her baseline is 2 to 3, mostly at night, PRN during the day. And currently she's getting 3, or they are getting 3 continuously. So they are independent. They've gone up to the chair 3 times. And they've had PTO and OT.
23 bed 1. They got to the chair once yesterday, so we need to increase getting to chair and work on pulmonary hygiene to see if we can get them back down to their baseline. If that's the only barrier, I mean, since they already have pulmonary 2, would we be able to just increase what they get?
Well, so if it's over 4 liters, we would need a new home O2 eval and then new orders. And then we would just need to make sure that their concentrator at home could accommodate their new liter flow. Because some only go to like 5 liters.
Okay, so let's have nursing try a Homo 2 eval today too, to just see where we're at today.
All right, let's do that.
Next is 223-2, followed by social work.
Initials RH, admit date 131, unknown discharge date followed by sound. Plan A is adult family home placement with guardianship. Guardianship date is 4/14, and he has a home and community services assessment today at 2.
All right, from nursing, this patient is medically stable. Their mobility is progressing a bit. They're attempting that. The patient is independent, but they're also refusing mobilization. So with this patient, let's continue to mobilize. Was there anything charted at all?
Let's doc refusals. This is when we've already done a palliative consult, and they're just not going to mobilize.
Doc refusals and.
So continue to try to mobilize and doc all refusals.
Okay.
Because there's nothing charted for mobility yesterday.
All right.
224, initials AE, admit date 3/28, expected discharge is 4/1. Plan A is home, and I plan to do a side eval with her today.
All right, from nursing perspective, this patient is unstable. They are getting IV antibiotics, Vanco and Unison for cellulitis in their neck. We are doing continuous OR as well. They're independent, they're ambulating.
There's nothing charted for mobility, so they're independent and mobilizing. We need to make sure nursing's documenting it.
Okay.
And then, well, I don't think it's appropriate for, I need a PO yet, so just monitor, the cellulitis.
Okay, next is 225 bed 1, initials PS, admit on 3/19, estimated date of discharge 3/31, followed by the Vancouver Clinic. Plan A is skilled nursing facility. Plan B is home with son and home health. We do have an accepting skilled nursing facility and insurance authorization for 3 days. Physical therapy was recommending Synfon 329. Case management is going to follow up with Hudson's Bay when the patient is medically stable. Discharge is pending decrease in bowel movements and oxygen needs per the provider notes.
Alright, from nursing, the patient is medically stable. They had a bowel movement on the 29th. They are still utilizing 2 liters of oxygen, although their baseline is room air. They are max 2-person assist with front wheel walker with us here. Are they, can we do like a home eval and see if that's gonna be a new thing for them?
Well, if they're going to a skilled nursing facility, they wouldn't need a home to eval. I think the concern was the frequency of the bowel movements they were having. So does that say how many bowel movements they were having, or just that the last one was on the 29th?
Just that the last one was on the 29th.
I know the day before they had several, I think 9 in total. So if we can look and see if their bowel movements have decreased and check, I mean, if labs look stable, electrolytes look okay, then potentially today.
I think that's good, and if not, nursing should be charting how many bowel movements they're having,
Yeah.
so we can monitor when they're appropriate to discharge.
So,
So they only had 1 bowel movement yesterday
Okay.
from during that shift, so.
during
they're-
yesterday's shift,
Yeah,
that's a
so-
Russian, so let's make them
I would say a maybe.
a maybe.
I
Okay,
would
let's
say
do a
maybe,
maybe.
if the nurse wants to follow up with me and just, let me know, then I will proceed.
Okay, and I have nothing charted for mobility on that patient, so if they're going to SNF, they need to be up and participating. So nursing action items are mobility and eyes and nose. And then follow up with, we can even say inquire with MD about potential discharge.
Yep, I've got that here.
Perfect.
Yep. Okay, next is 226 bed 1, initials PS. Same as prior patient. Admit on 329. I have an EDD of 330, but this patient needs to be evaluated still. Nursing?
Okay, so from nursing, they are not medically stable, they are a new admit to us. Let's see, they are in room air, front wheel walker. They have some wound care, they're here for an AKI. So I don't have a ton of information about them.
I have nothing documented for mobility, so, nursing needs to mobilize.
And assess VMOT, so we can see if we need a PT,
Yeah, you said they're here for what?
AKI.
Okay, so
Identification.
monitor labs, and assess,
They do
or
have,
immobilize.
they do have a new Foley catheter and, urine culture. They have some meds held for the AKI, and labs. And they see outpatient wound care for their right lower extremity.
What's the group?
The group Davis, is that TBC or family medicine? I'm not familiar with that provider.
I'm not familiar either.
Oh, Davis?
We'll figure it out.
Okay, we'll look.
Okay, next is 226 bed 2, initials HH, admit on 3/24, estimated date of discharge, April 1st, followed by sound. Plan A is home with Providence Home Health, Plan B is skilled nursing facility.
Alright, for nursing, the patient's not medically stable. It looks like we're using an NG tube, due to an SO small bowel obstruction. We got 2 liters of dark brown liquid removed during the shift. So they're progressing, but they're definitely still not stable. They're dependent, so bed bound, and their heart rate was a little elevated. So with nursing, let's just do range of motion and continue monitoring eyes and nose.
I inquired about higher level of care yesterday, do you wanna keep that?
No, I think they're okay to stay. Now that they've got the NG and they're getting some movement there.
227 bed 1, initials MC, admit date 3/28, expected discharge is 3/30. Plan A is home, plan B is home with home health.
Hi.
I don't think I have any barriers on my end.
I have a sheet for 27, you said 27 bed 1?
Yeah.
Yeah, no sheet. They were here yesterday. They mobilized in the halls 3 times yesterday.
We need a sheet for nursing.
Okay.
227 bed 2, initials SK, admit date 3/24, expected discharge is 3/30, followed by sound. Plan A is home with home health, and plan B is home.
Okay, this patient is not medically stable. Their NA is still low, so we're monitoring their labs. They're on room air. They're a standby assist with front wheel walker. Yeah, so it sounds like they are ambulatory.
Yeah.
Did they ambulate?
Twice in the halls yesterday.
Okay.
So really, we're just, it sounds like waiting on the
Electrolyte,
sodium
yeah.
replacement.
Mhm.
Okay, we'll see, monitor labs
Do you want
and
me to
inquire
keep
with
them
the
as
physician.
today?
Do we know what the sodium value was?
They just said it was low.
Yeah.
Okay, next is, 228, bed 1, initials JC, followed by Kaiser, admit 310, unknown discharge date.
From nursing, this patient is medically stable. They are comfort care. So their hospice has seen them already as well. So for nursing, comfort support, and just follow up with Kaiser Care Management to see kind of where.
It looks like we're awaiting, they don't qualify for Ray Hickey House, so we are awaiting a long-term care placement with hospice. They got 2 shared twice yesterday, so if they wanna get up, their comfort, so their choice, but if they wanna continue to mobilize, that'd be great.
Okay, next is 229, bed 1, initials CM, followed by Kaiser, admit on 3/28, estimated discharge date 3/31.
All right, this patient is stable. They are also a comfort care patient. So a hospice placement is in process with this patient. They do have a telesitter in place due to impulsivity. They're bedbound dependent, getting some morphine and whatnot.
Are they still on any restraints?
No. Just the telesitter. So
Yeah, we
comfort support.
DC'd restraints yesterday. So that's good.
Right.
Okay.
Next is 230, bed 1, initials DG, admit on 3/24. I have, unknown date of discharge, followed by sound. Plan is to discharge home with, a new outpatient HD chair versus Plan B is home with home health and a new HD chair. We need to follow with Delisa she's helping to coordinate that. As of yesterday, there was no chair available for this patient.
Okay, well, for nursing, the patient is stable. They do have their new fistula is healing, it looks like well. They're on room air, independent, ambulating. So I think it's just kind of waiting for that
So they are.
I have that they mobilized in the halls
Yes.
5 times yesterday, so good job on that. Let's keep them moving while they wait on the each teacher. So mobility is really our target if they're otherwise stable.
You got monitor site and IVs to PO. You want me to keep
There's
those?
no IV anymore,
Perfect.
Yeah.
so it must already be PO, yep.
Cool.
Next is 230, bed 2, initials PI, admit on 323, estimated date of discharge 330, followed by sound. Plan is to return to Glenwood with Peace Health Hospice. They are scheduled to discharge this morning, at 11 o'clock. AMR is gonna pick them up. They have a 1 o'clock intake, and the has been ordered, so.
Alrighty, yep, orders are in, so let's just prepare for discharge for this patient, please.
Okay, and I marked them as a yes for today.
Yes, they will be going today.
Okay.
Next is 231, bed 1. Initials DL, admit on 323. I have unknown date of discharge, followed by sound. This patient, is planning, he's here from Las Vegas, and his parents live here, so he's planning to discharge to his parents' house. And potentially a new outpatient HD chair. However, the referral has not been sent yet because he's still diuresing and hasn't needed the dialysis yet for nephrology. And so plan B would be maybe like going home to his parents with home health. He is non-insured, and does not have a primary care doctor. So we need to follow, application has been filed for Washington State Medicaid. He didn't qualify, but he may have to be reevaluated because I think he will qualify. And financial assistance application is in, so we're just monitoring that, to try and get him all set up once he's medically stable. Nursing?
Alright, nursing the patient is stable. They are room air, independent, ambulating plenty. They do still have a Penrose drain that was emptied a few times. Looks like they're also getting IV antibiotics, so for his facial abscess, so.
Am I able to, clarify, when reviewing the notes, it looks like the patient is still getting IV Lasix twice a day. Renal biopsy results are pending, and the patient had a fever per the notes, and so they were repeating the blood cultures and, possibly sending him back to the OR for another IND of his face.
Okay, they did the blood cultures on the 29th, renal biopsy was done as well on the 29th. I don't know about the diuresing, they don't have anything
Okay.
listed about that, but yeah, we could look into that.
Yeah, I think they just
I'll add it to
changed,
my-
I think they were gonna do a CT of the neck as well per ID because they had to change the antibiotics. So I don't know,
I can
Nursing,
follow up with her.
if we're still diuresing with IV Lasix, we need to figure out what the goal weight is and then inquire with the physician on when they plan to switch to PO.
Okay.
Cause it sounds like if he's not gonna need dialysis, then really it's just the IV Lasix.
it was kind of unclear. I think they were treating it as an acute kidney injury, but they were anticipating he was going to need dialysis because his kidney function.
Okay.
And so, but they're still working on that infection too, and so they're trying to renally dose, and so he's kind of complicated.
Okay, so let's make him not medically stable. Need to know for today. 31 bed 2.
There's nobody there?
Okay.
32, initials NC, admit date 3/27, expected discharge I have as 4/5. She is followed by sound. Plan A is return home when parents and DDA arranged caregivers. Plan B is a new adult family home. She comes from Roar and she's unable to return there.
Alright, from nursing, the patient is medically stable. They are at their baseline of 2 liters of oxygen. Pain's controlled, they're voiding appropriately. They sit at the edge of the bed. They're max like pivot / standby.
Nursing got them to chair once yesterday, so if we can make the goal for today up to chair 3 times.
Okay.
We have to verify O2 baseline.
Yeah, it's 2.
Let's do it.
2 liters.
And schedule toileting for the cat.
Yep, she avoided large amounts of urine on commode. The UA showed no UTI, so it looks like she's doing what she needs to be.
Okay, next is 233, bed 1, initials RG, admit on 3/25, estimated date of discharge April 3rd, followed by sound. Plan A is skilled nursing facility, Plan B is home with resumption of care with home health. So case management needs to call the daughter and update regarding the skilled nursing facility, follow up with the VA social worker. Patient will need VA transport at discharge, so there's a form that needs to be filled out to do that. And yeah. Nursing.
Which nursing the patient is not medically stable. We're doing IV antibiotics. Looks like they're on 4 liters of oxygen when they are a room at baseline. Let's see here. They're dependent, so bedbound with us, and they're requiring frequent reorientation and behavioral monitoring with them. So.
Yeah, obviously no.
Yeah, no for that. So pulmonary hygiene, yep, that's it right there, and range of motion. And document behaviors, I feel like they get assessed.
Let's see here. Next is 234, bed 2. So initials GM, admit on 3/20. Estimated date of discharge was previously unknown. I've marked it as a potential of 3/31, followed by the Vancouver clinic. This patient, Plan A is skilled nursing facility, Plan B is home with home health. The barrier is they needed an outpatient dialysis chair, which I believe has been obtained through the Vita. So care management is going to call ProMedica this morning about getting this patient admitted to them and submitting for insurance off. And then calling DaVita just to confirm all the details and adding that to the patient's after visit summary, and then updating the patient once I'm done.
All right, from nursing, this patient is medically stable. The port's intact, looks good, no infection, and encourage ambulation to the bathroom. Patient refused. But PT and OT did see them, and
We mobilized 3 times in the hall yesterday, so that much is good.
okay.
So essentially, since they have their chair, we're just waiting on insurance on with ProMedica.
Yes, and then we have Humana, so I'm hoping to get them out tomorrow.
Okay.
Because ProMedica sometimes can be a barrier over the weekend, so I'm gonna try and get them out, have them ready to be discharged tomorrow.
Okay.
Let's do it.
So, sorry, making myself a note. What are your nursing action items? Sorry, I interrupted.
Document mobility with this patient,
Okay.
and yeah.
His BM, did they have a?
The 29, we're good. Yeah, thank you. And refusals, that's good stay, yes.
Next is 235, bed 2, initials VW, admit on 3/29, estimated date of discharge April 1st, followed by sound. Plan A is to discharge home with patient's son. Plan B is home with home health. Case management's following for needs. Nursing.
Right, from nursing, the patient is medically unstable. They're still receiving IV antibiotics and IV fluids. They had a fever of 102, and then they had critical lab for positive blood culture, hypotensive. We did a bolus. Yeah, there's the heart rate. There's a lot of stuff going on with this one, so definitely not medically stable. They're room air independent, to standby assist here with us. Are they intubating?
I have nothing charted for mobility.
Okay.
So if they can, let's try and get them up today. monitor and treat the fever.
Let's do it a budget chair, maybe you might not be able to like walking.
Yep.
Chair.
Pretty cool. Out of budget chair.
Next is 236, bed 1, initial is PD, admit on 3/29, estimated date of discharge April 3rd, followed by the Vancouver Clinic. Plan A is to discharge home with home health, Plan B is skilled nursing facility. Occupational therapy recommended a skilled nursing facility versus IPRP. Physical therapy is signed in but hasn't seen the patient yet. I expect I'll see him today. The barrier for this patient is they live independently and their family is saying that they need a higher level of care because they, we're relying on the family and stuff and they're not able to meet their needs. So I'm going to call their independent living facility and see what kind of services they offer for a higher level of care, and then also submit the patient in ADA for skilled nursing facilities, pending them being agreeable to that, and then pursuing that.
Alright, from nursing, the patient is medically unstable. They're very, very weak, leans to the right. She has a hard time expressing herself, so I know POT did see her and helped with the transfer to commode, but that was all they were able to do. So I think we need to definitely follow up with the PT eval. She's new to us.
How old is she?
She is 78. It looks like they had a UA and orthos ordered for her too.
What are your nursing action
So,
items?
follow up with PT to see kind of what our mobility, where it should be at with her, to support that, and then, monitor, or do the ortho,
Orthos.
yeah.
Okay, so orthos and follow up with PT. I have nothing charted for mobility on that patient, so if PT says we can, we should need to at least get to chair today.
Next is 237 bed 1, initials HH, admit on 3/27, estimated date of discharge April 2nd, followed by sound. Plan A is return to their assisted living facility. Plan B is assisted living facility with home health. So nursing and care management is going to follow up with the assisted living facility to find out if the patient had behaviors at their facility because they were expressing maybe concern about behaviors for this patient. And they were wanting to maybe do an on-site before the patient could return. So I'm going to call and kind of get some further information on this and see where we're at.
So, night shift marked them as medically stable, but this morning, the nurse, the Foley has really bright red blood in it. It's clotting. They've had to flush it already. We've reached out to Sarah. She is having us trial remove it because we're thinking maybe CBI because he's been yanking on it and creating trauma. So she doesn't quite want to jump to CBI yet. So we're gonna remove it. We're gonna do Flomax. We cannot get him up. He's bed bound. But we're gonna try that and see if when we're doing the bladder scanning and everything. So
So nursing action item is avoiding trial for today.
He's bedbound?
yeah, he's a max with us. I know his baseline was supposed to be independent. I think
It
that's
says
why
he's
I
a
haven't-
beam out of 2.
It comes from Vancouver Retirement Community, and to my knowledge, they are a one-person standby assist max for their facility. So I'll call and look at, update them and find out any barriers to him returning and what we need to do to progress
Okay.
his discharge.
Let's have nursing as another action item.
I didn't see if he had PT or OT. I can look and then, follow up.
Let's have nursing reassess his BMAT too.
So is he in the lift room?
No, he's in a bed. No, he's not in a lift room
So
right
we got
now.
him in a lift room, could we do lift to chair?
Yeah.
Oh, of course. Yeah.
2381, next is 2382, initials MM, admit on 322, estimated date of discharge 331, followed by the Vancouver Clinic. Plan A is to return to an adult family home. Plan B would be a different adult family home. Discharge is pending improved behaviors and cooperation. You may need a site consult if the meds, that the med changes that they're making aren't helping with the patient's agitation and behaviors. So case management's going to contact the adult family home to discuss the discharge plan, and then contact them for an on-site once the patient is stable, so that they can, assess the patient for return.
Okay. So for nursing, they're stating that the patient's not medically stable. We're still doing the IV antibiotics, which we will switch to PO prior to discharge. Their lab monitoring PTOT is valve, bladder scan, and straight cathing this patient. They are dependent with us fully. PTOT and SLP have been ordered, only OT's been completed. But yeah, we did have to straight cath her overnight shift. Patient refused the lift and getting out of bed.
Okay, so we need to do range of motion, document refusals, and, bladder scans. And next is 239 bed 1, followed by social work.
Initials SE, admit date 316, unknown discharge, followed by sound. Plan A is adult family home, Plan B is home with adult protective services. He has a home and community services reassessment today at 1.
All right, for nursing, this patient is medically stable. They're independent, they're ambulatory. Yeah, no crazy behaviors noted overnight, so.
I have that he mobilized in the halls 4 times yesterday. And I involved risk with this patient yesterday. I got a hold of them, just so that they're in conversation regarding the family's
If he were to go,
concerns
yeah.
and.
Basically, I
discharge
was
plan.
told, like, if he tries to leave, to call DCR and do that process,
Okay.
or if he tries to leave AMA.
Okay.
Yeah.
So nursing should continue to document any behaviors and impulsivity, because it sounds like he is agreeable now.
Yeah, he was agreeable when I talked to
Placement.
him yesterday.
So
for now.
documenting all of that will help with his
He really couldn't, like,
daily rate.
I talked to him at 11, he was agreeable with his sister, I came back at like 2 o'clock, he did not remember the conversation at all, so.
And he still has a telesitter, is that
That's gonna be fine, yeah, he
Yeah.
needs placement.
Okay.
nobody in 39-2?
Next is 240 bed 1, initials CC, followed by Kaiser, admit on 3-2, unknown date of discharge.
So your patient is medically stable. We're just doing some wound care for her right now. She's fully dependent. The wound vac is on hold. She has a Foley. Yeah, so she's
She is awaiting, guardianship,
Okay.
so what are your nursing action items?
Continue monitoring the wound care, of course, and range of motion,
And document refusal.
document refusals.
Okay.
Next is 241 bed 1, initials RK, admit on 326, estimated date of discharge 331, followed by sound. Plan A and Plan B is for this patient to return to the Oaks. So case management action items are, following up to see if, there is any hospice or palliative care needs for this patient. And then following up with the Oaks as well for discharge planning purposes and with the patient.
Are they skilled or long-term?
I believe they, came from the skilled side, but they may actually need to go back long-term with hospice potentially, depending on if they decide, which way they decide.
Alright, from nursing this patient, they're stating that they're medically unstable because they're still requiring 0.5 to 1 liter of oxygen and IV antibiotics. They're here with COVID pneumonia and respiratory failure. CPTOT in hospice was ordered and completed, so I'm not sure,
Yesterday, the family was undecided on hospice. If they're going back to the Oaks and they're COVID positive, do we need to wait for them to de-isolate, or can they take them COVID positive?
I think, it depends on if their bed availability, and I have to confirm that. Some facilities will take them if the patient can be placed in a private room, and others, won't, so it really depends on what they have, so I'll follow up with them.
Okay, and then nursing should follow up with, infection prevention to see when we can remove isolation, in case that is a barrier. And then you said they're on half a liter.
0.5 to 1, and they're at
Okay,
93,
so
95, so I don't think that's.
Pulmonary
well
hygiene, we need to do
removed.
the IS and try and, we know to mobilize as we can. Nothing started for mobility yesterday.
Yeah, they're dependent,
Says we went to, so they should be getting up to
so
chair.
just a chair.
Next is 242, bed 1, initials GF. Admit on 3/18, estimated date of discharge, March 30th, followed by sound. Patient is returning to Americana in Longview today. They're gonna return skilled and then transfer to their long-term care side. AMR is gonna pick them up at 10 o'clock this morning, and the nurse has been updated, and the discharge packet is at the nurse's station.
Fantastic, prepare for discharge. 422.
42, initials NR, admit on 3/26, estimated date of discharge March 31st, followed by sound. Plan A is for the patient to return to their adult family home. Plan B would be returning to adult family home with home health. Case management is going to assist the adult family homeowner with obtaining a hospital bed for the patient if possible, and arrange wheelchair transportation at discharge. And we're monitoring therapy notes for additional needs.
Alright, so from nursing, they're not medically stable, their, blood cultures are positive, so we're doing IV antibiotics. Range of motion, they are dependent. And the CPTOT wound care has been seen. Yeah, and they had a bowel movement this shift too, so. Is that one of our goals?
Yeah.
Okay.
Your action items for today.
And with this patient, let's do a range of motion with them, and, I mean, IV2 feels appropriate.
Yeah, it's not
Or
appropriate.
It's not appropriate yet.
Okay.
Okay, next is 243, bed 1, initials GB, admit on 3/22, estimated date of discharge, March 30th, followed by sound. This patient's plan is to discharge home with his son, under BiPAP and outpatient palliative care. Nursing, case management has obtained a BiPAP. They're gonna be here between 9 and 11 to set that up. Son is aware, so he's going to come so that he can, be here when they set it up for any instruction. And then VA stretcher transport with oxygen is going to pick up the patient at 1 o'clock to transfer him home. So I'm just gonna confirm the BiPAP delivery, and update the nurse.
Alright, prepare for DC.
You said at 1.
Yeah, 1 o'clock pickup.
I'll touch base with the nurse too.
And I think that's
Our last one, 243 bed 2. TM.
Initials TM, admit date 3/22, expected discharge, I have it today. Plan A is Ray Hickey Hospice House, Plan B is long-term care hospice, basically just waiting for the.
Okay.
This patient's a comfort on our end, so let's just comfort support. This one.
All right.
Alright.
So I think mine looks a little different than the board. I have a tomorrow on 22 bed 1. If we can stick a T up there. I have a maybe on 25, but I don't have 23 bed 1. Did I miss that?
23 bed one, that one, I think they were, not stable, IV antibiotics and activity intolerance with oxygen, so we're gonna do a homo 2 eval on them.
Okay,
So
so let's take off, yep, the maybe for 23-1, and then I have the maybe for 25.
Maybe for 25 one, we are just gonna confirm their decreased bowel movements.
Yep.
And I'm gonna call the facility in case the doctor.
Oh,
Not
behind
you.
and then, I have a yes for 30 bed 2.
Yep.
I have a tomorrow for 34 bed 2. I have a yes for 42 bed 1. And a yes for 43 bed 1. And then, a maybe, I forgot my maybe on that, 43 bed 2. So we have 1, 2, 3 yeses. And we have 1, 2 maybes.
That's the problem.
Nope, we still have 3 maybes. I'm missing.
Is this one a maybe? Oh, this is one that nursing didn't have a sheet on.
Okay, let's keep on the maybe, I like your thinking. We'll see if we can get them
We wanted to
out.
go yesterday, so.
Yeah.
I'll let know.
Alright, so we are pretty far off from our goal of 7, so hopefully we can at least flip our maybes to yeses, and then, if we find anything else, nursing can escalate to care management for needs.
Sounds good.
Okay, awesome.
Thank you.
Go team!